Welcome to the AUA News Inside Tract podcast. Today's Inside Tract podcast is part of the Voices series, which is brought to you by the Diversity, Equity, and Inclusion Committee. Here we'll be joined in conversation with committee members, AUA members, and urologists from around the world to discuss how to build a strong, vibrant, and diverse urological community.
Thank you for listening to Voices. I'm Dr. Michael Davis. I'm the Chief of Urology here at the University of New Mexico, and I have the honor of being this year's AUA Gallagher Scholar. I'm happy to join with my fellow urologist and the AUA's Public Policy Council Chair, Dr. Mark Edney today, and we're talking about the 8th Annual Urology Summit in Washington, D.C. from March 3rd to March 5th. Dr. Edney, thank you for joining us.
Thank you, Dr. Davis, for having me. I really appreciate the opportunity.
So I guess we'll start off, this being the 8th Annual Advocacy Summit. And can you give us an overview of the summit and its purpose, kind of who came up with the idea, if you know, and how it's evolved over time?
Sure. You can go way back to the 80s and 90s when there was actually, at that time, a joint advocacy meeting in Washington, D.C. every year. And that was when the AACU and the AUA were working together with respect to an annual meeting. That changed a few years back where the AUA and the AACU decided to go their own ways. And AUA created its own Advocacy Summit. And we're in our 8th year now. And this really is what I call the main event for public policy and advocacy in the American Urologic Association, and really for the House of Urology. We certainly have members of AACU attend, members of LUGPA attend. It really is our big Washington national main event, and so it's extremely exciting. And looking forward to the 8th annual. We've got we're in the process of sort of finalizing the agenda. We've got a robust agenda. We've nailed down the several different asks that we're going to go to Capitol Hill and make pleas for that are most of the time tied to bills that are actively in front of Congress. Occasionally we'll make an ask that doesn't have a bill, but this year all of our asks should have bills assigned. And it's really about bringing urologists together, both experienced advocates. But also one of the things I really love about this conference is we've really focused in recent years on bringing in residents, in some cases medical students, young urologists, people really early in their career who start to develop a passion for this advocacy stuff and this policy stuff because it's addictive. And once you start to get involved, you want more of it. You want to participate more. You want to sort of see where else you can start to have influence. And so we've got a tremendous number of younger urologists and residents participating. We have the PAR, which is the Policy and Advocacy Residents Group, which is going to bring a bunch of residents into DC. Really excited about that. The other element of this meeting is we are increasing the presence of patient advocates for lots of these issues. And so some may or may not know that we've got, several patient coalitions that are operated under the Urology Care Foundation. But there's a Prostate Cancer Alliance, there's a Kidney Care Alliance, there's a Bladder Cancer Alliance. And these are patient-focused organizations that really are designed to broadcast the voice of the patient. And we are bringing several patient advocates to Washington, D.C., and we're trying to sort of organize how they can travel with us to Capitol Hill. Because I'll tell you what, when you go to a congressional office on Capitol Hill, we as doctors can talk about the science. We can talk about the need. There is no stronger advocate for changes in medicine than when you bring a patient into a congressional office, a patient hopefully who's a constituent, who says, this is what I need, this is what I'm not getting. It's an extremely powerful message. And so we're working on incorporating the patient voice into our advocacy efforts. And so, for all of these reasons, I'm extremely excited about the 8th annual.
Yeah, that's outstanding. The one thing I noticed, because I participated in the 2023 meeting and then the 2024 meeting, is the dramatic increase in participants, it seemed, between the two meetings. And it seems like it's something that is really becoming of interest not only to our learners, but obviously also to practicing urologists and wanting to make an impact, in healthcare policy. Um, so in terms of, you just alluded to it, in terms of the advocacy asks, this year, what's the focus? What are some of the ones that you're, um, bringing to Capitol Hill?
Yeah, so we've picked out 4 discrete asks. Some of them are repetitive, and that's okay. And once you get into this advocacy arena, particularly in Washington, you will learn that it takes several congressional sessions sometimes to move your idea through. So it's not a bad thing that we're going to be talking about some of the same things we were talking about last year. There is a new ask, and I'll go into that a little bit. But the things that have been sort of perennial for at least for the past few sessions, payment reform. It's everybody understands that the way that Medicare pays physicians is badly broken. It's the only system in healthcare that the federal government funds that's not adjusted for inflation. The hospitals get an inflation adjustment. The nursing homes get an inflation adjustment. Doctors don't. And so there's actually a bill actually sponsored by our very own Dr. Greg Murphy, who's a Republican representative from North Carolina. He's an AUA member. He's one of us. He's sponsoring a bill that we're going to get behind that ties Medicare payment reform to some fraction of the Medicare economic index, which, again, would at least give us some inflation adjustment over time so that we stop losing and at least start treading water with medical inflation. So that's a big one. Next is administrative burden, the burdens of things like prior authorization and other administrative burdens. And a chronic problem. It's a huge dissatisfier. It's a huge contributor to burnout, actually. It's an enormous expense for offices at the practice level. And it's extra time that docs don't need to. It takes docs away from their direct patient care, and it's burdensome administrative nonsense, essentially. And so there are bills, the bills that have been in front of Congress deal specifically with the Medicare Advantage program, and how do we address prior auth within Medicare Advantage, and then hope that there's a ripple effect into the private insurances. Next is workforce, and workforce really kind of ties up a lot of these other concepts. It's no surprise. You go state by state. You talk to almost any of our colleagues at these meetings, and you say we're understaffed. We can't find people. We can't get people to come and join our practice. And it's really reaching crisis level, particularly in the rural areas. And I'm not sure how it is in New Mexico, but I can tell you in Salisbury, Maryland, we're on the Eastern Shore, and it's rural. So we're 2 hours from Baltimore and DC, and the peninsula that we live on has gone in the last, say, 7 to 8 years from 15 to 20 urologists down to about 8 to 10 for the entire peninsula. And that catchment area is probably 750,000 to 1 million people. So what that necessarily means is longer waiting lines. You can't get into a clinic. I mean, my waiting list is out 3 months for elective stuff in the clinic. And your operative list is the waiting lines are starting to back out. And when you combine that with shortages in other specialties, for example, interventional radiology, we've got a very spotty interventional radiology call list.
Mm-hmm. Yeah.
And so when you talk about infected stones coming in from an outlying hospital half an hour away, when I get called, my first question to the operator is, do we have an interventional radiologist on call? Because if I can't get a stent in and the patient is septic, they can die within hours. I mean, these are, as you know, these are really sick patients.
Right.
And so it's caused me in some instances to say, I don't have IR backup. I don't want to risk this patient's life. You need to get them up to the city. And there have been anecdotes around the country of people, healthy people with infected stones bouncing hospital to hospital to hospital, in some cases dying with a very treatable condition because of lack of expertise available in the localities. And so these are the sorts of stories we need to start bringing to Capitol Hill, not only shortages in urology, but shortages across specialties, including interventional radiology, that we've got to address, because Americans are suffering undue morbidity and indeed mortality because of these shortages. And the stories just don't get told, because these things happen in our hospital systems, and it's a tragedy. But there's no reporting mechanisms. So that's one of the things I really want to do, is figure out how do we start building a repository of these stories that we can actually bring to the lawmakers. And so the other thing with workforce is, there are GME bills every year. Right. And there are a couple that seek to expand the number of GME slots that are funded by the federal government. As you know, they were frozen back in 1997. And since then, there have been some increases in GME slots, but they've all been funded with institutional money. So it's money that universities will take out of research dollars, or right, perhaps with some industry support or something. But the federal government stopped funding new GME slots back in 1997. That's got to change. And one of my ideas around that I keep sort of whenever I'm in congressional offices is that it's a tough pull for the number of GME slots we need. It's a tough financial pull to put it all on the back of the Medicare budget, because Medicare is going broke, actually. And so, when you look at the number of residency slots we're going to need, to say, here's 15,000 new slots, you Medicare now need to pay for it. It'll break the system, and we need to figure out a way to entice. And there's actually some models for this. The medical device industry and the pharmaceutical industry, benefit significantly from new doctors who order their products and order their medicines. They have a direct financial interest potentially in starting to fund the training of more people to do those things. There's just no current mechanism for that. I mean, there are one-offs of industry supporting a fellowship here or a fellowship there. But I want to figure out with members of Congress and with other policymakers, how do we more formalize their participation in the funding of additional GME slots? And so that's another conversation that sort of is ongoing.
Yeah, alluding to or getting back to your previous point about, the shortage of, at least in our specialty, but specialists in general. New Mexico is a very rural state, and, you have catchment areas that patients have to be, transferred to. And, recruiting into academic urology has become really onerous, at least in our experience here in New Mexico. It's very hard to recruit because, I think trainees see the frustrations of their attending physicians and, potentially want to avoid some of the frustrations that they're going through. And so, my big question, to you, and I'd like to hear your opinion about, who's going to train, this large volume of trainees that obviously we need to, increase the supply of. And and I would hope, like you said, maybe incentivize, even in other settings, faculty to participate in training, new specialists, because I think, that's a problem. I see it on the academic side. So I think that's a problem as well.
No doubt about it. I completely agree. And, I work at a large regional hospital that was never designed as an academic center. And in the past 3 years has developed now 6 or 7 different residency programs. So we got internal medicine residencies. We've got general surgery residencies. We're not affiliated directly with the university. We're just a big, regional medical center with a lot of pathology. And so I think you're exactly right. It's, when you do that, I mean, that's going to be part of the solution, is having these large regional medical centers that may not necessarily have a direct relationship with the university, creating residency training slots. But when you do that, it's often done from an administrative standpoint. And that's how it was at our hospital. Our CEO went out and said, we're creating these residency slots. Then, and he got all the approvals, and then he went to the attendings, the doctors, most of whom are in a private setting because that's where they wanted to be. They didn't necessarily want to be teachers. And so you've got to have that conversation of, because it's a whole different, it's as it's a completely different ballgame when you've got medical students and residents around. The structure of your practice, the number of patients you can handle in a session, the structure of your day and the flow of your work is very different. And fortunately at our place so far, there have been enough attendings to sort of be willing to agree to slow down a little bit, teach and actually enjoy the teaching part of it. But that's a challenge when you start to expand outside of academic centers. It's you got to convince the attendings that, no, this is something worthwhile, and it's actually fun when you start teaching and you start to experience it. But some people just don't want to do that. And I get that. I mean, everybody's got sort of different personalities, but it's a potential challenge.
Yeah, and I think too, I think the C-suite sees it as a grow your own kind of labor force, which is also helpful instead of having to go through recruitment costs. You've got your own, you're kind of training your own labor force. But yeah, it's definitely going to be a challenge in the future, I think. Um,
But
so, are there any policy priorities related to health equity that will be discussed at the event at the Advocacy Summit?
yeah, I mean, to the extent when we talk about health equity, we talk about barriers to access for various populations of patients that just aren't, that need our services, that aren't accessing our services, whether that's, sort of minorities or socioeconomic folks of that are have challenges that way. When we talk about workforce and payment, I mean, all of those things, the more the workforce depletes, the less access everyone has, including folks who've chronically been challenged for whatever reason, uh, for access. So when we work on these things, that just by definition is trying to improve access. And so I would say that all of our asks sort of get towards equity through supporting the workforce, keeping people working longer, and adding more people to the workforce. I mean, that just sort of by definition should increase access. There's another policy issue that I want to sort of put before the audience. And this has, with respect to the Research Appropriations Committee, which is a component of the Public Policy Council. One thing with the change of the administrations, and this actually, the conversation about this started in the last administration, but the whole notion of NIH reform, their funding actually ran out, and so the NIH needs to be refunded by Congress. And with that, there's been a lot of conversation about reforming NIH and reducing the number of constituent subcomponents of the NIH for efficiency reasons. A big concern for us is the NIDDK, which is National Institute, I think, of diseases of diabetes and diseases of the kidney.
Right.
The NIDDK is the biggest funder of non-cancer research in urology. And so when they talk about either consolidating or changing that somehow, we got to pay close attention. And so we're trying to stay very involved in that conversation. I haven't seen any bills yet this session, but there are definitely groups in Congress who are eager to reform the NIH, consolidate it, and sort of streamline its processes. And we've got to pay very close attention to that. And, one of the concerns with respect to, equity is making sure that the research that gets funded, the participants in the research, how do we broaden out the populations of people that we do research on? Because, historically, there have been some research studies that are very poorly represented by minorities, ethnic minorities, racial minorities, other sorts of minorities. It tends to skew white, and some of that's the demographics of our country, but I think also some of that is not aggressively seeking those other interested constituents, these folks who are underrepresented, to participate in studies so that the results are actually more actionable. Because it turns out, obviously, I mean, it makes sense to all of us who have trained. There are racial differences. There are ethnical differences with respect to our physiologies and our genetic risks and how we respond to different treatments. And these differences need to be represented in our studies. And so that's one of the kind of the offshoots of NIH reform. And one of the things we're paying attention to is make sure that whatever NIDDK looks like post-reform, that we're funding studies in building mechanisms to invite underrepresented minority folks into studies, and figuring out what those barriers are. I mean, there's a reason that they're not invited, but part of it also could be lack of trust. I mean, you talk to some of these populations, they don't trust the medical system. They're not going to sign up for a study because they don't trust. And how do we how do we have those conversations? How do we build that trust so we can collect that data and actually provide better care to everyone that we need to care for?
Yeah, that's a great point. I think that once again, coming from New Mexico, we have a large Native American population here, and I think you look at cultural barriers to trial participation, and it definitely decreases participation. I think simply not having resources to to help with those cultural barriers. And so it's, but yeah, it's that's, and I'm also, it's good to talk to you because I had no idea NIH was looking at this major reform. Um, so that's, I mean, obviously that has implications for a lot of downstream effects.
About it.
Yeah. Yeah. So how does AUA work with lawmakers to advocate for more equitable access to urologic care as well as issues pertaining to urologists? What are kind of the nuts and bolts in terms of the AUA working with lawmakers?
Sure. So we've got a full-time staff in Washington, D.C., and it's led by a vice president whose name is Brad Stein. And we've got a full-time staff, and we have lobbyists, full-time lobbyists. And so we've got a DC office who regularly reaches out to congressional offices and maintains these relationships. Speaking of congressional relationships, I've got to put a plug in for the PAC. The thing that makes these congressional relationships work and maintain and strengthens them is the AUA PAC, your AUA PAC. So every listener to this podcast, if you have not contributed this year to the AUA PAC, please log in. You can log onto the website, AUA PAC, and whatever you can do. It's not necessarily about the dollar amount. It's about developing an every year habit of contributing to the AUA PAC, because that is the driver of the relationships that we have in Congress. And it's not a quid pro quo thing. It's we contribute to members of Congress. And then, separate from that, down the road, a bill comes up. Hey, are you willing to co-sponsor this? Can we get a meeting in your office? And if we've been a contributor to their campaigns, we are much more likely to get a meeting in their office. In fact, much more likely to get co-sponsorship of the bills that we care about. So I can't underscore enough how important it is that every listener to this podcast contribute to the AUA PAC. So please do that. But back to your question. So we've got a full-time staff in DC. And so we talk about the summit. That's our main event. That's when we all descend on DC. And we all, as urologists and as patients and as advocates, get into the offices and talk about our asks and our bills. But that's once a year, and a lot of the work is done kind of on a day-to-day basis, outside of those meetings. And that's our AUA staff, our professional staff in Washington, that's going to fundraisers, going to congressional offices, putting a bug in their ear, reminding them this is really important to urologists. And we also, we don't operate in a vacuum. We also, are part of alliances, specialty medicine alliances. So there's the Alliance of Specialty Medicine, which is a multi-specialty alliance, which also has an annual meeting in Washington that I go to and several other AUA members go to. And that involves, rheumatology and orthopedics and, lots of other subspecialties, because, it turns out a lot of our issues are issues in common, and your voice is stronger when you get together with the others who are affected and you go en masse into these congressional offices. It's a bit of a stronger voice. And so that's another mechanism by which we influence members of Congress. But that's functionally really how advocacy in Washington, D.C. works.
Okay. Yeah, that's a very clear answer. And I don't think, I didn't know until I started getting involved with the advocacy meeting, how large a presence the AUA has in terms of, the legislature and Washington. So it's really been eye-opening.
We've become, it's a specialty. We've become a well-respected brand. And as the AUA PAC grows, and I'll put in a plug for the AUA PAC, this past year, we reached our goal. And I think this is its 4th or 5th year of operation. We raised $100,000. And that was the goal for this year. And we want to get this PAC. I mean, this PAC eventually needs to be $1 million PAC. We'll get there. We've got plans. We're expanding sort of, again, reaching out to groups in urology that maybe necessarily haven't typically thought of contributing to PACs, making that value proposition. But one of my main objectives for my chair years here over the next 3 to 4 years is to really expand this PAC. Eugene Rhee and Kevin Koo did a phenomenal job of getting it started and off the ground. We've got to rocket boost this thing. We got to get it to the next level. And so that's part of the effort here. But yeah, we raised $100,000 last year. Huge milestone. Really proud of this. And now we're gonna shoot for the next milestone.
Yeah, and that's another thing. I mean, just reminding everybody to contribute, because obviously, this takes funding, and so contribution is in your best interest in terms of um, getting the urologic community's representation in Washington. Um, so why is it so important that urologists learn about the issues the AUA is advocating for?
Because this, this affects what you do every day. And there are lots of urologists, and I've met them, and I've had guys in my practice over the years who are just not particularly interested in either going to the state house or going to the Capitol or getting involved in the politics of urology. That's okay. If it's not your interest, it's not your interest. But it ultimately affects what you do every day, both the stuff that happens at the federal level, in some cases, even more so, in a lot of cases, what happens at the state level in your state capitals, with respect to sort of, regulation and what you're allowed to do and not do for your patients, insurance regulations, medical malpractice regulations. A lot of that stuff is very state level. And it affects your life, your malpractice premiums. Can you continue to afford to pay your malpractice premiums? What's going on at the state level with the laws that are such that your medical malpractice premiums are going through the roof? What are the trial lawyers doing? So it's not that everybody has to be directly involved, because I understand some people just don't like the stuff. That's okay. At the very least, what I ask of people is contribute to your PACs, because not only do we have the AUA PAC at the national level, but your state urologic society likely has a PAC. If it doesn't, your state medical society has a PAC. Fund them, because they're looking out for your best interest in the state capitals, and that's the best way to sort of support the work that they do, because ultimately this does trickle down to you and your practice in your life. And when adverse things happen with respect to regulation or the cost of this or that, or your ability to get something for your patient you now can't get, okay, that usually started in the state house or with some regulatory body in your state. And it's okay if you weren't paying attention, but you need to help the folks who are paying attention so they can advocate for you.
Right. Well said. So, how can attendees actively engage in advocacy efforts before, during, and after the summit?
So, yeah, lots of things you can do. What I usually counsel folks to do is make a list, make a spreadsheet of everybody has a representative in Congress. You're in a district. You've got a representative. Figure out who that is. You've got 2 senators in your state. Write down their contact information. You also, at the state level, you're in a state district. You likely have a representative. Most states, I think other than Nebraska, are bicameral. So you have likely a state representative from your district where you live, and you have a state senator who covers your district. Find out who they are. If you don't know, I mean, a lot of people know who they are, but if you don't know, find out, Google them and figure out, write their names down, their office numbers down, keeping in mind that their state office where they do their legislation is different. And it's by law different than their campaign office. So they will have a set of contact numbers for their campaign, because those are kept very much apart. They can't commingle campaign staff with, organizational staff at the state level. Write down what you want to do is meet them. Okay. The best way to do that is contact their campaign staff and figure out, most legislators can't hold fundraisers while they're in session. Okay. Lots of states have rules against that. So whenever your state legislature goes out of session, call their campaign office and say, hey, when's Representative so-and-so's next fundraiser, and go to it. And the nice thing about the state level is that you can get on the radar screen of your state representative or senator for so much less money than a member of Congress. You've got to get a member of Congress or a senator $1,000 before they'll remember your name. At the state level, yeah, at the state level, you give somebody $100, $200, they will remember your name. They will put your contact in their phone, and if you can become the urology contact when something comes up, when they're doing their legislation in the state house, and some doc issue comes up, I got a doc in my district. I'm gonna give him or her a call and ask what their opinion is about this. You start to become the go-to person for your legislator, and it feels great to participate in that way and to become kind of the go-to person. I've had that experience in my district. I'm very good friends with my state senator, who calls me all the time and says, "Hey, this thing's come up. What do you think about this?" And happy to sort of spend the time. But it's a lot of things in politics are transactional. And again, it's not a quid pro quo, but you've got to contribute. That's the whole thing. I mean, because politicians care about two things, whether you're at the federal level or the state level, they care about two things: money for their campaign and votes. Okay.
Right. Yeah.
So you need to come to them with some value proposition of, listen, I want to help you. I think I can be of help to you. You can help me. And here's how this happens. And your end of it is make a campaign contribution. And you don't do that in the State House or in the Capitol. You can't pass checks in those buildings. You go to their fundraiser, introduce yourself. Hey, I'm Dr. So-and-so. I'm in the practice down here. I practice urology. Really like to get to know you. Here's something for your campaign, and have a conversation. And it doesn't have to even be about politics. Talk about your kids, talk about what you like to do. It's forming a relationship. It's the relationship that's most important. Then when something comes up, you can pull it up and say, hey, now that we know each other, this thing's going on and we feel very strongly about it. So, if you could help us with that, that'd be great. But it's, these campaign events are about just interacting socially, becoming friends, and learn about them. They'll learn about you. That's the whole mess. And it's actually, when you do it, for those who like to do it, again, not everybody does, but for those who enjoy this stuff, it gets really fun. It gets really fun. You look forward to it.
Yeah, it's something that I think most of us don't think about, and that's forming a relationship with, either our state legislators. Obviously, probably the easiest and like you say, most affordable. And that's and then the going to the federal level. But it's something that to be honest, I haven't really thought of much until I got involved with this. So where can listeners go to learn more and get involved with AUA's advocacy efforts?
Yeah. So if you go to the main AUA website, there's a huge advocacy component there. There's also links to the PAC. And I, again, strongly encourage folks to just give a little bit of money to the PAC. Don't have to be a huge amount. Just do it. It's the act of doing it. And say, do it every year. But the AUA website has a huge policy and advocacy portion of the website. It's got a lot of the things that we talk about here and some other information. And if you can make it to the summit, please register.
Absolutely.
Yeah. Let me give you the dates this year. It's in March. Starts on March 3rd. So people will get into town Sunday night. March 3rd is a Monday, and it's going to go Tuesday, Wednesday, and it'll let out Wednesday afternoon. So March 3rd, 4th, and 5th of this year. Please, if you're interested in this stuff, please come to the summit.
Yeah,
engage in the conversation.
I'm looking forward to see how many attendees. I mean, the attendees seem to be going up year after year, so I'm excited to see the number of attendees. And this could get as big as a regional or a meeting at some point or bigger.
Absolutely.
The last thing, for you personally, what ask are you most excited for this summit?
Yeah, it's the stuff around. It seems it's a great question, because there used to be kind of a rank order of these things. It seems like everything's a crisis now. I mean, I'm really feeling the workforce crisis. But as I said before, a couple of the other asks feed into that. Payment reform, getting people sort of adequately compensated from Medicare helps maintain our workforce. Yes, the GME bills maintain our workforce, but it's all of those issues around maintaining the workforce, adequately getting urologists compensated from the federal government, which work in tandem, which together increase access to patients who need access for our care. Because at the end of the day, that's why we're here. We're here to provide care for the people that need it. And if there are people that can't access it for whatever reason, it's our job as advocates to break down those barriers. And that's why we're in Washington. And that's really what's behind these asks. There are Americans with urologic problems that need our help desperately, in some cases emergently, and in some cases can't get it. A lot of cases can't get it for a variety of different reasons. Again, whether it's barriers based on race, ethnicity, socioeconomics, whatever it is, we've got to address those barriers and we've got to break them. And so that's the magic of this summit. I mean, that's what we're doing. We're trying to improve access. That's why we're bringing our patient advocates with us to Capitol Hill. Don't listen to us, listen to them.
Right.
They're not getting what they need. And please fix this. And so that's what's really fun. And, you kind of leave at the end of that and feel like, I think we delivered the message, and you wait and see, and things don't happen overnight. It's not like, necessarily the next month, there's going to be a bill that passes because we were up there. But it's the constant slow trickle in pressure on these members of Congress to say, hey, we're back again. And guess what? We're asking for the same thing because you know what? It's still a problem. And here's a patient to tell you about it. And when you make that continuous effort, eventually it works. And we've had some successes in the past. And that's why it's fun. That's why we do what we do. And that's the value of it.
Yeah. No, I that's one of the great things about getting involved with this is hopefully, advocating and seeing the change, over time, obviously, but it is exciting to get involved. I think the one thing about the healthcare industry, I should say, is that, it's interesting. I was reading in one of the bill for that was going to increase Medicare compensation or Medicare remuneration, that over 2 decades, I think, physician compensation has dropped by something like 22%. And
26%.
26, sorry.
Yeah.
Thanks for correcting. And it's what other industry does that?
No other industry.
And so I think, it's so our voices need to be heard, obviously, and for a lot of different reasons. There's a labor shortage, and then there's a compensation issue, and so it's anyway. Well, I appreciate it, and I think I don't have any other questions. So
I think we covered the beachfront. I think it was a really good conversation. Thank you for doing it.
Yeah. Oh, my pleasure.
This has been Voices, an AUA News Inside Tract podcast, and is brought to you by the Diversity, Equity, and Inclusion Committee. For more information about the AUA's diversity, equity, and inclusion efforts, visit auanet.org/diversity.